basically a video-based session, and we will try to cover up, and there is a point for interaction. You can ask few questions, and again, we can try to reply as much as possible. We can. So basically, I am planning for A to Z care of the lacrimal drainage system here, and my first speaker is, she will speak from the age. Chronologically, congenital is one of the issues in our countries, and she will speak on congenital epiphora, the consequence, and how we can tackle it. Dr. Srituja, please.
So, at the outset, I'd like to thank Dr. Jayanta sir for having me in his course. Yeah. So, I'll just briefly be covering congenital epiphora, and basically CNLDO is the topic. So, when you have a child with epiphora, you mainly evaluate the child starting from the puncta till the nose. And what we'll be mainly talking about is how to manage congenital nasolacrimal duct obstruction. Now, all of us know the basic anatomy, and this is the diagram that we all sort of work with. I think this is stuck. Thoda freeze ho gaya hai shayad. Yeah, okay. And starting from the punctum, it's important to know where the punctum starts, where the canaliculus starts, where it ends, where you can expect a hard stop, a soft stop, and where the meatus opens, the middle meatus and the inferior meatus, because these are important landmarks when it comes to evaluation and management. Now, with respect to the watering eye, it could be either hyperlacrimation or epiphora, as we are planning to discuss in this instruction course. So with evaluation, it's not only the meticulous history taking, but also a good external examination and diagnostic tests, and when required, for example, in traumatic cases, you need imaging. Now, in the history, when there is watering in general in a child, you need to know, is it unilateral or bilateral? Is it constantly overflowing or intermittently watering? And is there any seasonal variation which could indicate that there is an allergic component? Other than that, the type of discharge would also indicate if there is any pain and swelling involved, if there are any nasal symptoms, and various other symptoms which would indicate corneal issues or uveitic conditions. Now, with respect to the past history, is there any previous attack of adnexal inflammation or infection, any sinus disease or ENT pathology which needs to be treated before we treat the CNLDO, any trauma, and any surgery done in the past? Along with this, any topical medications that they are on, also it's helpful to know. Now, with examination, the external examination includes also the nasal examination and the diagnostic and secretory tests, which I'll be coming to. So, for example, if you have a child like this, this is a condition called dacrocele, and it most commonly results in a respiratory obstruction. So, it necessitates a surgical intervention before you go into any imaging, and it happens at a very young age. And the most important thing that we check in our OPDs before we even go into the syringing is the RO+, or regurgitation on pressure over the lacrimal sac. I'm sure we all know how to do this, and this is the most commonly done. Now, in a child, doing a fluorescein dye disappearance test is extremely helpful because they are not cooperative usually for a syringing unless they are older children. So doing a fluorescein dye disappearance, especially doing it in both eyes, helps you see the difference between both eyes. In one eye, there would be some retained dye even after 5 minutes if there's a nasolacrimal duct obstruction. So with respect to probing, so before you go into the syringing, the probing interpretation is again very important. Like I mentioned, knowing the anatomy helps you know where the hard stop would be and where the soft stop would be. For example, here you can see at the common canaliculus, if there is an obstruction, you get a soft stop. The probe doesn't go and touch the bone. Now for syringing, syringing has some important findings that we need to interpret. So if there is clear fluid from the opposite punctum, it could be a common canalicular block or a nasolacrimal duct obstruction. But if there is definitely mucoid fluid, it's the nasolacrimal duct obstruction. If it is partially patent, it's a partial obstruction. If it is patent but there is epiphora and sac dilation, it could be an atonic sac, which is actually there in older people. And regurgitation of clear fluid from the same punctum indicates a canalicular block. And mucoid from the lower punctum, when you do through the lower punctum itself, could be a NLDO with a upper canalicular block. So it's important that you make sure you know where the stop is happening, what the nature of the fluid is, and whether it is coming from the same or the opposite punctum. Now, with respect to congenital nasolacrimal duct obstruction, probability of spontaneous resolution up to 12 months of age is quite high. And after 12 months of age, it keeps reducing gradually. So it's important that we target these patients right at the beginning within the first year of age. Now, management can be conservative or surgical. Conservative, as we all know, is the hydrostatic massage. But how the massage is performed is actually very key in these patients resolving spontaneously. So it's important that you mention to the patient that it is a hydrostatic massage, which means you need to apply pressure at the medial canthus. Not only that, it has to be done repeatedly. So at least 10 times, 10 strokes to 15 strokes, around 3 to 4 times a day, and that would be the best way to open up the membranous obstruction. Now, the age for surgical intervention is, of course, after 1 year. And till when do we do probing is again a debatable topic, because people have attempted probing even in the teen ages, so even at 13, 14 years of age. And first line of treatment after the Krigler massage doesn't work is, of course, probing with irrigation. The second, if the probing with irrigation fails, then you do a repeat probing and with a silicone intubation. So when do you probe? Again, this is after 4 months of age, and 4 to 8 years is considered delayed in the older times, but not so much now, because a probing can be successful even in older children. So the technique, of course, is the nasal packing, a technique for the passage of the probe. I will be demonstrating that also in a video, and the confirmation of the patency. So it's done under general anesthesia. A syringing is first performed to check the canaliculus also. And you go ahead from the upper punctum, go downwards, backwards, and laterally. So success rates, again, for probing keeps reducing with age. So if it's done earlier, it is better. And the first probing has, of course, a higher success rate than the second probing. So immediately after the procedure, it's important that you advise that the patient gets some kind of nasal decongestant and nasal steroid sprays, steroid antibiotic drops. And along with that, as far as possible, tell the parents to avoid anything which might trigger an allergic reaction or a cold or cough in the child. Complications of this include bleeding, a false passage, inability to pass the probe down later, entry into the submucosa of the lateral wall. Basically, any type of false passage can take place, and after failed probing, you may get a bony obstruction later with age. Now, how do you manage a failed probing? Like I mentioned, the repeat probing and the intubation. Now, when there is an inferior turbinate which is obstructing the inferior meatal opening, you need to do an inferior turbinate infracture, wherein you go in with the periosteal elevator and you sort of medialize the inferior turbinate to create that space for the opening to come up. So you can see this periosteal elevator here, and once you get a good space to put your periosteal elevator at the inferior turbinate, you go in and medialize it. Now, you confirm the patency by blocking the other punctum, and then you put the syringing through the other punctum. Now, with respect to intubation, you can have a monocanalicular intubation or a bicanalicular intubation. The bicanalicular is usually preferred, such as the Rittling. And they are similar with their success rate. However, personally, I prefer the bicanalicular. We can discuss later what experiences everybody has. And again, it is done when there is failed probing, or it's preferred to be done along with the DCR when it's done in older children. So some of the complications are that you could have extrusion of the tube as well later on, but that's less common with bicanalicular intubation. Now, balloon dacryoplasty, not performed by us that much anymore, but the basic thing is that you go in, keep the probe along with the balloon inside the area with the suspected blockage, and you inflate and deflate in these timings the balloon, and later on you would find that the opening is patent. The other thing you could do is a nasoendoscopy assisted probing. That is where you visualize the lower end of the nasolacrimal duct, like how you can see beyond this inferior turbinate, and you can see that the probe is coming through. If you don't have an endoscope, you can just do a metal on metal contact with the probe touching the periosteal elevator. Now, of course, DCR is done after the age of 4 years. I think it will be discussed, this will be discussed anyway. And newer modalities are dacryoendoscopy. And the recent opinions, like I mentioned earlier, was that people are trying to do primary probing in children even between 8 to 12 years of age before offering the DCR surgery. So this is a rough outline of how you would generally manage a case of congenital nasolacrimal duct obstruction. And thank you.
Almost cover almost everything A to Z. But there are just few points you are mentioning. To the patient, I just mentioned after the word lacrimal sac pressure. Just
right.
Modify.
Hydrostatic.
Moment you can tell a massage, they will do along with the servant and grandmother, and everyone is touching this part. So it's a very small, 8 to 10 mm, or maybe in pediatric 8 mm. So is it basically pressure? With that finger is pressure is enough. Just instruct the parents to demonstrate first. Those are the punctum area. You should close the punctum or canaliculus. Common canaliculus is very difficult, but you can close the punctum. Moment if you are safe to close the punctums, but parents are very happy if there is a Roplus is positive. Their thought is comes out. This is a wrong. To create the hydrostatic pressure, it should be inside. Very nice. Salu, please start. Okay. Yeah.
I would just add that what the technique you showed, Dr. Rutuja, we should keep in our mind that whenever we are just doing probing and when there is bleeding, that means it has entered into the NLD itself, because NLD itself is covered by vacuoles and with lots of blood vessels. So if you're new to do probing, better use olive tip probing. So that will not create the false passage and you're sure that you have opened the Husner's valve only. Thank you.
And another point I want to say that Rituja mentioned we can do it along endoscope, because as we are doing probing under GA, so it is not justifiable without endoscope, but is not possible. That question is not impossible in if as in every eye setup. So in such cases, one small modification we can do, we can use the indirect light, at least with the nasal speculum. With the indirect we can see lots of the thing. We can focus by indirect light, or even from the microscope there is a light source. If in your PR surgeon is doing some surgery on that particular microscope, there is a light source, you can just look and directly you can see instead of endoscopy.
It's not visible. At the outside, I'd like to thank Dr. Das for including me in his course. So we all know the periocular injuries are fairly common when we encounter the facial trauma, and among these the eyelid and the canalicular injuries form the major part of the periocular injuries. So most commonly these are encountered following a direct or can have an indirect injury. It can be due to following a blunt trauma or a penetrating injury. And commonly we have seen these with the dog bite injuries or a blouse hook injury in a lactating mothers. The basic mechanism which has been shown that because the medial canthus encases the lacrimal sac, so it weakens this area. So whenever there is an injury in the lateral canthus or a malar eminence, it causes the pull of the medial canthus laterally, and thus basically pulls the medial canthal tendon away, and along with it we have a lacrimal sac injury, and thus leading to the avulsion injuries. So high index of suspicion should be kept in these all cases who have a injury in the medial canthal area. Some of these can be obvious and easily identifiable. However, whenever in doubt there are occult injuries, we should pass the probe through the punctum, and if we see the probe basically in the soft tissue, it indicates the canalicular injuries. So this was the example, the clinical example showing with the pencil injury, the injury in the direct in opening the lacrimal sac area. So both canaliculus are important and should be repaired if any of the canaliculus are involved. Timing, we all know the early repair is preferred. However, if we encounter the patient present lately, we should explore it and try to repair it, as literature has shown that it can be successfully repaired within 5 to 7 days also. The basic principles involve identification of the medial curtain, approximating the curtain around the stent, and retaining the stent for adequate period so that we have the proper can maintain the patency of the lacrimal duct. So basic is the identification of the curtain. Whenever we see, we know sorry, this is no. The videos are not playing.
Please help.
Yeah.
Play.
Yeah. So if the medial curtain is near the punctum, so they are easily identifiable. However, the difficulty lies when there is a avulsion injury and the distal curtain are quite medial. This is the pearly white cuff ring which is easy, we can identify, and we know that this is the medial curtain. So the key to identification of this medial curtain is the use of high magnification, like with a microscope, or you can use the loupe and with the good illumination. However, if we are not able to identify the medial curtain, we can use the technique of air injection through the opposite normal punctum, or the saline or dye which is passed through the opposite punctum, and thus it helps in facilitating the identification of the medial curtain. You can pass the probe through the medial curtain and you feel the heart stop. So the basic key is that you first put all the tissue in a normal anatomical position, and you can in 90% of the cases identify it if you are using the microscope. Some of the surgeons prefer pigtail probe to use the pigtail probe through the normal canaliculus. However, I don't use it because of the sharp edges of the pigtail probe. Stenting, if it's a monocanalicular injury, you can use a monocanalicular stent, or if it's both canaliculus are involved, then use the bicanalicular intubation, or you can go individually repair them with a monocanalicular stent. The most commonly used is the mini Manoka stent, and if it's not handy, you can use the IV intracath cannula. 22 gauge is easily available to us and can be used. And after passing the stent, it's a pericanalicular suturing is required with 8 ovicular suture. This is the clinical video showing the patient had both lid laceration with the lower lid canalicular repair was done. So after punctum dilatation, we pass the probe and identifying the medial curtain. And as the lid was retracted, we first pass the suture through the orbicularis with the 5 oviculars so that we can bring it closer, and thus we can facilitate the passing of the stent. So you use the punctum dilator, and you can shorten the mini Manoka stent and can bevel the end so that it can help in facilitating pass through the punctum easily. And this collarette is snugly fits into the punctum. and then you pass the other end through the medial cut end and perform the pericanalicular suturing. These pericanalicular sutures can be done either 3 sutures can be passed, one anterior, one superior and one posterior. Some surgeons prefer doing 2 sutures, some do 1 suturing. So it's basically the surgeon's choice. After the pericanalicular suturing, we repair the margin and rest of the lid laceration is repaired following the normal basic principles. This is another interesting case where instead of the horizontal canalicular cut, it was a vertical cut which was passed through the punctum and the vertical canaliculus. However, the horizontal canaliculus was retracted medially. So we passed this stent. This is the medial cut end. So we passed the mini manoka through this medial cut end and reform the punctum and the vertical canaliculus. So the pericanalicular suturing was done so that we can make the new punctum here. In this case, we have also passed the suture through this collarate to the surrounding tissue because we don't want to prevent the extrusion of the stent. And the rest of the suturing was carried out. This is some of the clinical example. The patient had an avulsion of the medial canthus, and this on the table reconstruction. This child has a occult injury and was taken up for OT on suspicion of the canalicular repair. In this, this was the earlier repair where we have used the intracath when mini manoka was not available to us. So this is the fixation of the intracath Teflon. So the complications are very few with these mini manoka stenting, like extrusion, or you can have cheese fire of punctum. And if done properly, repaired and in an adequate time, we can have a high success rate as much as 95% with this canalicular intubation. Thank you.
You just cover in all every. So just one point you mentioned in one case. See. Once it is correct, if it is the cut is nearer to the punctum is okay, but if it is very nearer, less than 1, less than 1.5, there is a possibility of cut through.
Yeah.
In such cases, my technique is always I should not dilate with the punctum.
True. Yes.
Moment you can dilate, sometimes it is a 1 mm, it may be a cut through, and again you made a reconstruction, again punctal reconstruction. So you can just pass, it will be easier. And you mentioned.
But the basic problem we face is passing the first tube through the punctum only. So we have to bevel it and make it slightly sharper edge.
And be careful under the microscope. It is for that audience. You are nicely done. You are very expert. So, but for a beginner, so dilate the punctum little bit, not full. If you can try to full, like in our SC entry, we are making a full entry, then there will be a leak in the AC. So like that, if you go for full, then there may be a cut through. That's another point. Second is that you mentioned mini manoka. Yes, mini manoka is best, but there is a very costly and not easily available in all over India. So that's the reason. One is AIOS stent is easily available, not too much. It is almost approximately you can doctor's price is around 2.5 to 3,000. Written price is slightly high, so we can use that AIOS stent also equally good. What AIOS stent quality, as the quality of the silicon is not as good as like mini manoka. Mini manoka is the first one who introduced is a research product, so is sometimes little difficult to pass the AIOS stent, but it is work very good, low cost. Dr. Shreya with us now. She will speak lots of the newer advances. If you have any comment, if you want to give any input, please most welcome from anyone.
Yeah,
any question?
Dr. Shalu, actually the most important part in your previous talk with Dr. Shalu, actually the most important is to find out the cut end of the canaliculus, which is very, very difficult. Even after doing, even in 10%, it's difficult to find out that cut end. So we have developed a newer Drashti canaliculostomy intubation set, which has got, it's based on pigtail, but it's not thick as pigtail, it's not sharp as pigtail, it's blunt tip, small cannula, which is exactly with the curved of common canaliculus. You can pass through the non-injured end of canaliculus, it comes out to the cut end of the canaliculus only. So you don't have to search for the cut end of canaliculus. At the same time, behind that cannula is the silicone tube itself. So you have stent now ready, available with you. And the most important part is the same one stent can be used in 10 more patients. So it's cheapest of the cheapest option available with the surety of finding of cut end of the canaliculus. I'm very grateful to Dr. Das sir for allowing me to speak in his IC. Thank you so much, and we know how much work he has done for oculoplasty and the trauma. So I'm really grateful, Dr. Das. So here I'm going to talk on small incision external DCR. So we all know DCR is really bread and butter for all oculoplastic surgeon, and everybody must know this. And there are many techniques available, conventional DCR, where we're used to put such a large incision. So here I'm going to show you the small incision DCR. In our Drishti Netralaya, out of 5447 lacrimal surgeries, nearly 1205 was canalicular surgeries, and DCRs what we did was 4195, and IND of course in 47 patients. So conventional external DCR is taught to us in our college time, and still it is a gold standard. I'm not against that, and it's very good surgery. The only thing is cosmetically it gives a very, very large scar. So nowadays patient may not accept, or sometime it comes with the granulation also. Transcanalicular laser DCR is also a wonderful technique where there is no scar. You can have a sharp aiming beam. You can see through the endoscope. You can just puncture, and it's very, I must say, it's very glamorized surgery, and you may have to support it with stent also, because it has got very small opening. The complication sometimes happens when the patient blows the nose post-operatively. There can be emphysema. So it's not a good it's bad complication, and you should take care of that. Endonasal DCR, of course, is very good surgeries. We do endonasal DCR in a hospital, but it needs quite extensive skill also. You have to have thorough understanding of nasal anatomy, and sometime you may have to take support of ENT, which we are not taking in our hospital, but with the passage of time you can learn endonasal surgeries also. Then we developed in our hospital transcanalicular manual DCR. So that was just a simple cannula what we designed. So one fine day I was not able to do anything, and suddenly what happened that after puncturing, after dilatation of lower canaliculus, I just passed a small blunt tip cannula which has got side opening. I just passed through the lower canaliculus, and I just pushed into the lacrimal bone, and you know lacrimal bone is very papery bone, so it opens through the sac. That doesn't mean we have just opened very small hole into the canaliculus, through the canaliculus into the sac. So that worked very well. We did this technique in lot many 7 to 9 patient, and we published this also in the Indian International Ophthalmology with this many result. Though it was long-term result, definitely will not be good, because it was simply a simple internal IND, as well as you can even do pre-cataract surgery. So it's very easy, but long-term result, I would say it was not good. So based on this technique, 6 months result was very good, but based on this technique, we just tried intracath Teflon sleeve DCR, where you can just pass the intracath, 22 gauge sharp long intracath you can take. You can pass through the canaliculus, enter into the middle meatus, confirm it through the endoscope. But mind you, the intracath material is not an inert material, because body throws it within 7 to 8 days. So even if you are using intracath material, that Teflon sleeve material of intracath for your canaliculostomy, that also extrudes very fast because it's not an inert material. So we tried this technique also in 34 patients. Then came a small incision external DCR based on our own experience of transcanalicular manual DCRs. So this the anesthesia is simply infraorbital anesthesia. I'm not going to into detail of the anesthesia, but technique, if you can understand, just simple dilatation, you can just get this hard stop, hold the cannula in one hand, then you just puncture near the bone where exactly the sac lies. You can just puncture with the cannula. So now you know that the cannula is through the canaliculus, through the sac, it is into the middle meatus. Then again I puncture through the skin. There should be a metal to metal touch, not the soft touch. That means your blade is touching to the cannula, which is already into the middle meatus. Now you can take the perforator. Again the perforator has to touch to your cannula, which should be metal to metal touch, and then you can puncture the lacrimal bone. So you can confirm it also through the nasal endoscope, then supported by silicone intubation. Any of the stent material you can use. Here I don't have any financial interest. We are using this material since long. You can see through the wound, the patency you can confirm. But at the same time, you have to confirm the patency through the lower canaliculus also. This confirmation of the implant with the help of endoscope also we did in AIOS2025-IC591 surgeries. And you can see even simple, you don't have to pass the fluid. You put the fluid and it goes. It's very large opening, so it doesn't seal with the silicone tube itself. We measured the wound, and most of our patients' skin wound was less than 5 millimeters. So we name it as a SILS, small incision lacrimal surgeries, because people are now going behind SICS and SIMS. So it's SILS surgery. We used this technique same, even the angular vein was cut. I'll not go into detail of the this video, but even with the presence of angular vein cut, you can just cauterize and you can go ahead with the same technique. It's very easy. You can implant and then you can proceed with this surgery. When there is a common lower canaliculus block associated with NLD block, we can use the Teflon sleeve for temporary purpose, which you can confirm also through the external wound. Post-op, after 1 month, you cannot see any scar, so it's as good as endonasal DCR also. Expected result is in the late stages. It is expected that the presence of tube into the lacrimal bone halts the process of healing of the osteotomy. So you're sure that the osteotomy will not close. It facilitates the migration of sac epithelium around the osteotomy and continues with the nasal mucosa, which all know what the DCR means. And these form a permanent opening with the small incision external DCR. We see this patient day 7, week 7, and then 6 weeks. I usually prefer to use endoscope also in our OPD area, and we see what is there into the nose also. Post-operatively, definitely antibiotics and everything can be done. But sometime there can be causes of constant epiphora. So the reason can be early causes, plugging of the distal end of the silicone tube itself by discharge, mucus plug or blood clot, plugging of the distal end of the tube by nasal mucosa, because nasal mucosa starts healing within 7 days. Late causes can be the tube itself. If you're not put properly into the intracystic place, then that can be a abnormal placement of the tube, that can be extracystic, and there can be sometimes some syndrome, which I'll tell you in this talk also. Nasal endoscopy if you can perform, and sometime we may have to take CT DCG help also. Sometime you have to remove the crust. So as I said, it's just mucus plug which is covering the distal end of your implant. So you remove that and the patient is happy, which is already which can be done even in outpatient department. So out of this are if nasal mucosa is there, you can just use the technique of transcanalicular manual DCR. The name we have given is cannula DCR. Transcystic position of implant, if it is done, their patency on the syringing through the wound intraoperatively will be definitely there, but when you go through the canaliculus, there will be sac contracted. So collapsed sac will be there, and then later on come with the Epiphora. Extracystic definitely, because it's not taking cyst in sac in the wall, so there will be a patency intraoperatively, but later on it comes with the constant Epiphora. Dislodgement or incomplete placement of implant can happen, and if this dislodgement happen, if the implant comes anteriorly, there can be a sum syndrome because fluid gets collected under this implant. Sometime extrusion of the tube happens and we remove the tube. So in such one or two patient, we had to remove the tube after extrusion, and in this kind of patient, then I performed the external conventional DCR, so which is still gold standard, but with a small incision external DCR, we have still 95% success rate. Sometime we may have to take the combination of the techniques. So this external DCR I'm just showing because the tube was explanted. And some of the time when only nasal mucosa is the covering part and blocking the passage, I put bicanalicular intubation through this bigger silicone implant, which prevents the nasal mucosa to cover the distal end of the canaliculus. Sometimes granula can happen. What is ideal? Laughing patient is an ideal. I am grateful to my teachers, I am grateful to Dr. Das, and I am grateful to all of you for patient listening. Thank you so much.
It is a new one, so there may be intubation, but one thing for everyone is not possible because that you need an endoscope. That's a one of the big problem with us is maximum institute that's a very costly. Endoscope is very costly.
Absolutely.
And that's the another.
So in that case, what right now we are just telling people that if you are not able to spend for endoscope, you can just pass the fiber optic cable through the canaliculus and then look through the nose. You'll get the sharp aiming beam where you can see exactly there the sac lies. Thank you so much.
Dr. Sir, how long you are, if you are using a silicone tube, how long you are keeping it over there?
It's for lifetime.
Okay. Any complications you face like granuloma formations, infections and all?
That's what I showed in my presentation, because one patient had a granuloma formation and one patient extrusion, because it develops the SAM syndrome. So as we say that Krigler's massage, so sometime adult patient also start moving here and there. They take out the tube from the osteum itself, so it comes anteriorly into the sac, and then slowly it comes anteriorly, then extrusion
and while
happens.
putting the cannula, like I feel how you are doing it, it's like
it's exactly 45 degrees. So when you just passed cannula through the lower canaliculus and move your hand 45 degree, you'll definitely get the lacrimal bone and you can puncture anytime.
You told the metal to metal touch, no?
Yes.
So it's with the punctum dilator you are going to like...
No, cannula is already there in the middle meatus.
Yes.
Now you are cutting.
Yeah.
So that should be metal to metal. That means from skin you are cutting the sac and entering into the sac. From the canaliculus you have entered the sac through the canaliculus.
Thank you so much.
You just press. You just press because it has got frenal end.
You can sit and
Thank you. Thanks, Dr. Das.
So, Nilanjan, your question? Yeah. No. Please ask. I am preparing that one. So everyone, always we are speaking so many things. It's not connected. So there may be some unusual causes. Most of the time we may overlooked, and with a very successful surgeries also, sometimes there may be a failure. What are the causes? It's not moving. Not showing on the screen. That's why I told you to come early to save time.
Hello, please
Yes.
help.
Not connected. Huh? Okay, now it's fine. So this is just a nutshell on here. So we can look. There may be some causes in punctum. There may be following injury. There may be scarring. That's another point. There may be a scar also in some areas. And another important is the membrane. Membrane over the in between the canaliculus, common canaliculus and the sac. following repeat infection, suppose there is a history of cellulitis or acute necrosis earlier in such cases, there is, those are the, if we can do a very successful this year, there may be failure. Through endoscope, if we do the surgery, maximum the surgeons are doing now in an endoscopic, then also there is just chances of failure. And those are uncommon. I am not moving. Not moving. Not moving the slides. Hang, I think. So, this is very, most of the time we may overlooked. There is a punctum. In the punctum, the ilices. Because one ilices is generally pointed, or that root is generally bigger. So if it is in reverse direction, it's enter little bit, or it maybe go up to that punctum also. That's another cross. In my career, till now at least I remove 6 or 7 ilices from the punctum, and as it is almost, it was touching the other punctum, is erode the other. There is a some punctal inflammation in the other, and there is Epiphora. And the patient was doing syringing to the lower punctum. He was treated, and it was not properly taken care, and that's the cause that foreign body, the ileus is one of the foreign body in upper punctum, is erode the lower. So be careful on such cases. If you doing syringing, maybe patent to the lower, there may be a cases, and patients are even treated by glaucoma, steroids, so many things, but that simple thing, you just look carefully, remove it. Sometimes it may be very, very difficult to see. You just, with the baths, you can clean and you can see the ilices. So, very interesting case of this lacrimal sac. Is it a referred to me for a lacrimal sac mucocele? But there is no history of Epiphora. When I asked, I did the, all my previous speaker mentioned there's a, we can go for those diets, etc., etc. Even syringing was done for confirmation. It is the things. Then I realized something is there. Just a send for CT scan. Radiologist again mentioned cystitis. What to do? So then I inform or do the syringing. Just introduce a probe inside, and inside, in such cases you can go here necrocystography, otherwise no such situation. Thus so just I explored own, just I thought it may be some lipoma or something like that, the growth. So I just exercise like any DCT kind of thing and remove it. Is just like a one in toto mass. Next I once I remove it is a in toto mass. So then I was in, it's not a lacrimal sac, almost sure. Then I just cut in the OT, inside the OT. Moment I cut, there is a worm. And if you look, when I transfer it to the bowel, it is moving. And just it is confirmed, it was a thalassia, very, very rare. It was published in IGO also, it's a thalassia. So, always this is a mandatory. If you are a little bit in suspicion, then you can send toward histopathology, and at least before sending, you can cut also. You can cut, and with a direct illumination, you can see the gross examination. This is our part, because I did the gross examination. That's the reason you can publish. Otherwise, if I not do that gross examination on the table, so the pathologist again tell is a inflammation it. So finish. There is a sometimes nevus, very big, rapidly growing nevus. What to do in that? It may be Epiphora also. So my take-home message in such a thing, if there is there, so always use probe. Again hang. This is loose, and so then you can introduce the probe, and you can dissect carefully and intubate. Like in a canalicular injury, you can intubate for a moment. Once the granulation starts, then after 6 you can remove. The same thing is in the growth again. What is the method to remove the growth? Is in the video I am showing, not a good quality video in my mobile.
You can just click on that.
Yeah.
Thus you can click.
So just remove step by step little bit, and then don't pull as a whole. It is just maybe stuck somehow because of that quality of the computer, I think. So you can remove, and then you can just wait for a moment. Then you can observe under the microscope, and if required you can use a mitomycin. There is a granuloma sometimes may happen like this.
It's not moving.
It's not moving
Video
at all.
is not. You can just show from the outside of your.
Okay, outside I will show the video, and repeatedly I will finish it all. So then we can look the punctum. If any suspicion, then with the wood hole pull tool we can do the thing. And as I mentioned, if there is a scar, so there is a endoscope is there. If there is a endoscope is there, we can do with the endoscope, lacrimal endoscope, but it's very, very costly. So that's the reason you can just different you probe, you can pass it, and after that you can intubate it. This is one of the options. Next is that how we can tackle the membrane. If there is a membrane, if we do a perfect DCR, maybe by through endoscope or external, there may be chances of failure if we do not remove the membrane. In my video, I will try to how we can remove the membrane and how we can identify. This is basically in a common is if there is a history of cellulitis earlier. In such cases, so moment we can just go ahead with whatever endoscopically or externally you can go ahead as like you can just remove. Then I will show you the next thing. You can prepare the, if you want a single flap, you want a double flap, whatever flap. Now few surgeons are doing triple flap. That's not the issue. But you just exercise, and if you look carefully, the inside the sac inside is not so, that is a whitish membrane like thing. It is here, it is visible, not on the screen is not exactly visible, but here it is means that is a whitish membrane kind of thing, is whitish, not so much. So that's the suspect. And then once I probe it in between the common canaliculus, and there is a sac, there is a membrane is there. That membrane you should remove thoroughly. With intubation and after doing the surgery, it generally retract, but it may not retract also. In such scenario, then if we can remove nicely, then it can be done. So this is the three few points where those are hidden causes. And if you are doing in a under loop, you may miss those type of membrane. If you can remove that thing, then it will your success status as equal as this. So there is a apple thing up under apple tree, and then I just want to show you my another video where I just punctal growth. If it is work, then I can. There is some. Here it is PLC media is I think not available. Oh, is already closed. Can you open it up? Just connect it. That video.
Good evening. How are you?
Base of the base scissor you can use, just hold. This on the punctum. It looks like on the lid, but it is not. It is growth from the punctum. Then with a penis you just try to locate, and with a very blunt dissector, and in this particular area just avoid any bipolar or monopolar cautery. Moment you can use any cautery for the bleeding, there may be a scar for permanent. That's why very carefully, like we are doing in cataract surgery, capsular, then you can try to slowly, gradually pull it out, and there's a bleed. Moment you can pull it out, there's a bleeding. Don't be panic, because from the base, once you can remove the base, there's a bleed. Then you can, with the help of the bath, you can press for a moment, and you can use mitomycin C, because in once there is some growth, I don't want to put any intubation. That's why, as it is in. So if we can control, now the punctum is facially visible and bleeding is reduced now. So just wait few minutes to stop the bleeding. Again there may be bleed. Again you can wait, and once it will be totally stops, then till now you can just press it, or you can, once it stopped, then you can use the mitomycin C. That's a very good results. Thank you. I just finish early little to for that interaction. Now I request that any query on that?
Yeah, just what was the, you sent for HP?
Yes,
What was
yes.
the
It was a granuloma.
granuloma? Okay.
Papilloma
And anybody from you have come across dacrolith? Because I got one patient who had a dacrolith constantly collecting in the canaliculus. So in that case, what would you like to do?
Yes. And in dacrolith, generally in a long-standing cases, repeated attacks of chronic dacryocystitis, but in this particular patient there is no
Yeah,
such
it was
state. It is a
granular.
gradually increasing in size. Patient observing, intelligent patient, consulted several places, and everyone talked there is something in the punctum, so there may be. But I explain, you will go for that, and we do the biopsy, and then is biopsy confirm it, and then main thing is that is still pattern without intubation.
Sometimes granuloma gives lot of bleeding actually.
Yeah.
Bleeding. That's
Pediculated,
why.
that's why
That's
it
why
was
wait
one
lots
vessel.
of time. Lots of time. It may be you may wait even 5-10 minutes, whatever, or then generally it stops, but it may bleed. Just I request my next speaker, Dr. Nilanjan, to speak on this, because it is in maximum number of patients are in a community-based patient. In our, we are facing that disease profile is not in a higher socioeconomic group, because of the lower socioeconomic, because of the poor quality of hygiene and the diet, or so many things. The environment may be one of the factors, and it is not, we neglected also. There is a two reason. One is a retrograde and an antegrade infection. In both the antegrade and retrograde infection from the surrounding is very high in case of a lower economic group. Dr. Nilanjan, please.
Kindly make it full screen, no? At the onset, I'd like to thank Dr. Jayanta Kumar Das for giving me this opportunity to speak in his instruction course. So, good evening, everyone. My topic is a little bit hatke from the normal videos and all. So, I'll be speaking on the magnitude of lacrimal diseases in the community. So, the slide is not moving. Okay. I've got no financial interest. So let me first come to the dacroadenitis. It is a uncommon condition, and we find in 1 in 10,000 ophthalmic patients, mainly identified in children and young adults. So coming to the lacrimal gland tumors. So these tumors have a yearly incidence of 1 in 1 million, representing the 10% of orbital space occupying lesions. Here is the overall breakdown of the lacrimal gland tumors. 55% are benign and 45% malignant. Now we get nasolacrimal duct obstruction, the most common disorder of the lacrimal system, leading to the acute or chronic infection. So it has got a bimodal distribution. You can find congenitally just after birth or in adults more than 40 years. Now these are the conditions which can lead to Epiphora. Now coming to the risk factors, older adults, females, patients with chronic eye inflammations, patients with eyelid surgery, nasal surgery, sinus surgery, patient undergoing radiation are at increased risk of nasolacrimal duct obstructions. Now coming to some of our studies, actually there are very limited data available. So this is a prospective study carried out in northern India by Khatun et al. So they found the prevalence of dacrocystitis to be 19.5 cases per 10,000 patients, and the incidence rate was 15 cases. Now they found chronic dacrocystitis to be more common. Majority of the cases were due to primary nasolacrimal duct obstructions. And they saw that the disease was very prevalent in the lower socioeconomic status, and housewives and farmers were more commonly affected. So this is another study done at Cuttack, Orissa, where they found the prevalence of chronic dacrocystitis to be 1.224%. Now this study was carried out at Hyderabad. It is in a tertiary care center. It is a retrospective study. They found the two most prevalent disorders are primary acquired nasolacrimal duct obstructions, followed by congenital. And the most frequently encountered proximal lacrimal disorder was punctal stenosis. Now here are two of the studies, one done at Odisha and another at Maharashtra. So both of them have highlighted that chronic dacrocystitis was more prevalent in 5th to 7th decade of life, and it was more seen in the lower socioeconomic status. And interestingly, housewives were affected more than secondly are the farmers. So all the studies have shown that the frequency of nasolacrimal duct obstruction was more prevalent in the females. So this is another study done at LVPI Hyderabad. It was a retrospective study. So mainly they found acute dacrocystitis comprising 2.4% of the patients. There was no difference in laterality, and 23 eyes presented with lacrimal abscess. So the mean time for resolution of the acute symptoms was 10 days, and 5.6% developed fistula. And there was spontaneous rupture leading of the lacrimal abscess, and dacrocystorhinosomy was performed in 82.5%. And they found that 2.8% had orbital cellulitis. Now coming to the microbiological profiling. Now this is a prospective study which was done at Karnataka, where they found that coagulase negative staphylococci and Staph aureus are the most common isolates. Now this is my own study which we did at Southern Assam, and we found that in chronic dacrocystitis, the main causative organism was Staphylococcus aureus and Pseudomonas. But in acute dacrocystitis, we found Staphylococcus and mixed flora. Now a similar study was done by Jayanta Kumar Das et al. In Northeast India, showing similar microbiological profile. That is, the majority was gram-positive Staphylococcus species and gram-negative was Pseudomonas. Now this study was carried out at Arvind Eye Hospital, and they did a retrospective analysis of the dacrocystitis patient, and they found that 30% had acute dacrocystitis and 70% had chronic dacrocystitis. And they found that Staphylococcus aureus and Pseudomonas was higher in acute dacrocystitis, while the proportion of coagulase negative Staphylococci was higher in chronic dacrocystitis. Now coming to the source of infection, it can be from the conjunctiva, it can be from the nasal cavity or nearby nasal sinuses. Now Jayanta Kumar Das et al. Had a publication, and they have highlighted that the maximum growth was from the nasal mucosa, that was 90.7%, followed by the lacrimal sac and the conjunctiva. Now all the studies have highlighted that the chronic dacrocystitis was more prevalent in lower socioeconomic status group. Why? Now maybe there are poor workplace environment, no proper protective measures, poor hygiene among the patients. So it also contributes to their poor knowledge regarding disease condition and awareness regarding maintaining a good hygiene. And also this is very important that poor socioeconomic status directly affects their poor affordability to health facilities. Now this is a case of primary tubercular dacrocystitis, which was reported from a case of 15-year-old female with history of 8 months Epiphora. So this is another unusual case of Epstein-Barr virus associated dacrocystitis. It was reported from 2 children in the United Kingdom. Thank you so much.
So before Sir start, so if you have any questions, please collect all those questions. We can try to one by one. Sir, please.
Thank you, Dr. Jayant. Thank you for the privilege of being a part of this lovely course, which I have been a part of for the last few years, and it is a very popular course. The talk that I'm going to give you is about some of the changes that we've had in our practice of lacrimal diseases over the last few years, which have contributed to better results in these cases. So we will talk about changes in the congenital nasolacrimal duct obstruction, where we find that in failed cases, particularly inferior turbinate in fracture is a major contribution, because it creates that additional room for you to either be able to endoscopically see it, find the area where the probe is protruding, and to be able to take care of those complex cases. Balloon dacroplasty is another area, and endoscopy is certainly the one major change that has taken place in management in congenital NLDO. So we will talk about them in the context of the failed cases. Acquired obstructions, we'll talk about the punctal obstructions, where there has been a change in thinking and in approach, so that probably the amount of surgery that we were doing earlier has reduced significantly. Canalicular obstructions, we will talk about the cistler trephination, and we'll talk about the newer approaches for making conjunctival DCR a much simpler procedure, and there again endoscopy plays a major role. In the acquired nasolacrimal duct obstruction, we'll talk about the endoscopic dacrocystorhinostomy. There is also a non-endoscopic transnasal DCR, which we do not have much experience of, and transcanalicular recanalization is another area. These two areas have become important, but we do not carry these out. So transcanalicular recanalization is again through an endoscopic approach, which has been designed specifically for going through those canaliculi and recanalizing it under direct vision. So I'll talk about the procedures that we normally use in our practice. So talking of failed probing, the various approaches that you have is, if it has been done in somebody else's hand, then you can repeat that probing, usually with a gap of at least about 6 weeks. But if you've had a failed probing in your own hand where you are sure that things went well, then you probably need other approaches. Cases where the persistence of Epiphora is present are many a times because of close approximation of the inferior turbinate to the nasolacrimal duct opening, and therefore the inferior turbinate in fracture alone suffices in many cases, even if you do not have access to endoscopes. Balloon catheter dilatation is a costlier approach which can be used in resistant cases, and we'll see what role it has. Silicone intubation is certainly an advantage in special situations, which we'll again talk about. And endoscopic assisted probing is the most important newer advance in cases where there has been a failed probing. And beyond 3 years, of course, if you have a failed probing on 1 or 2 occasions, then you need to create a dacrocystorhinostomy, and these are usually the cases which have a bony obstruction or the nasolacrimal duct bony canal which is not developed well enough. So inferior turbinate in fracture is generally carried out under general anesthesia, and after initial vasoconstriction of the nose by nasal packing, usually using a good concentration of adrenaline, as much as your anesthetist would allow, you can get a good hemostasis and then cause the inferior turbinate to be rotated in, so that the area where the nasolacrimal duct is opening can be free from any obstruction due to mucosal swelling. Many of these cases will have intermittent probing, so whenever they get a little congestion in the nose, they tend to develop watering and discharge again. So the use of a generally artery forceps or more often a periosteum elevator gives you the feel of the inferior turbinate, and you can fracture it in 3 different motions, doing the anterior part first, then the middle part, and then the posterior part, and you give a very clear give, and you can create that extra space which allows the success of many of the failed cases. But where you can combine it with an endoscopic observation of where the probe is appearing, it helps increase the success rates. Now, balloon catheter dilatation is a modality which has been available for quite some time now, and it is particularly useful in failed intubations, complex cases of nasolacrimal duct obstruction, which is defined as the abnormal openings, which are the where nasolacrimal duct is not opening into the inferior turbinate directly, but also it has been used as a primary procedure. Now, the advantage is that it allows greater dilatation because balloons are directed, they give a pressure radially on the duct once you have opened the obstruction, and therefore they do not produce tears, and it is a relatively less invasive procedure. However, results are not any better than intubation in cases of failed probing according to the large multicentric PEDIG study, and they are costlier. So this has balloon size of 2 millimeter for up to 30 months of age, and a larger balloon is used for older patients. And then you carry out 2 cycles of balloon inflation at 15 millimeter marking and at 10 millimeter marking when you have pushed it. And first cycle of 8 atmospheric pressure, second cycle of same pressure for 90 and 60 seconds respectively. This is to give that sustained period of dilatation, and this is how you create the pressure with an injection, and the balloon here inflates, and once the balloon inflates, it causes a dilatation of the entire canal. Now this is how you carry out the procedure, and for those much time, but since the results have not been shown to be much better than the intubation is carried out more often. Now let's look at the role of nasal endoscopy, which I think for congenital cases is the major advancement that has taken place. Especially useful again in the same situations, complex NLDO, failed probing, and there are those cases where there is a congenital dacrocystocele. Now these cases often have a nasal cyst associated, and sometimes they are bilateral. Now these are the cases where nasal endoscopy is important, and possibly having an ENT doctor with you who opens up those cysts and marsupializes it. We know that many of these children, if it is bilateral, can have a respiratory distress as well. Now success rates with endoscopic guided probing have been shown to be much better, both in primary and in failed cases. These success rates become much higher. So let's see an example. Here we are passing the probe, and we will carry out an inferior turbinate infracture to create more space, and you can see that inferior meatus is now much more roomy, and you can see the tenting that is taking place is within the mucosa. It is not coming out through an opening. So we are using a sickle knife in order to create the opening where the indentation is seen. So where you see the indentation, you open it with a knife, but you know that this is an artificial opening that you have created, and therefore you need to carry out an intubation in order to make sure that this will not get obstructed again. If you come out through the natural passage, normal passage, intubation is not necessary. So you have all these tubes designs available. You have the Crawford tubes, which are the standard ones that are used, but there are various other models now available which help in easier intubation. The shortcoming is the extra cost of those, Nanchuk or the other models that are now available from FCI. Now the acquired obstructions, one of the most common problems we face is a punctal stenosis, and this is often due to the antecedent inflammation caused by meibomian gland disease in many of these cases. And the problem in many of these cases is that they are not simple punctal obstructions, but may be associated with further obstructions down the lacrimal passage. And it is for this reason that you need to evaluate and consider your options very well. So when you have a punctal stenosis and both puncta are obstructed, patient is troubled by epiphora, you can either have conservative approaches, non-surgical or surgical approaches. So non-surgical approaches include reducing exposure to external breeze or blow of fans, etc., which will produce more watering and more water and therefore cause epiphora. You can try to open the puncta with laser, but the most popular now is the use of botulinum toxin. Now botulinum toxin is reconstituted and we use 2.5 milligrams in the palpebral lobe of the lacrimal gland from the conjunctival approach, and this is a simple procedure. The advantage is that almost 80 to 90% of these cases respond and the effect lasts for about 6 months. If you inject more, the chances, the only side effect that you often encounter is up to about 10% cases developing ptosis. Now, various studies show a high resolution rate, up to 60 to 90% of cases do well with this, and in these cases you can repeat the injection whenever the symptoms recur, and very often almost 8 out of 10 cases would show a permanent response and be happy with this, and you can avoid a more complex bypass procedure or conjunctival DCR that we are going to speak about. So the commonest complication is about 8 to 10% of transient ptosis, which lasts a few weeks but can then go away. So we have had a very high success rate with these, and it has cut down our conjunctival dacrocystorhinostomy rates. So these are the various surgical options, but the ones that are used most often are snipping the punctum and putting in a perforated punctum plug, which is again available now, or doing a snip procedure, either a single or a 3 snip procedure. So you try and make the initial opening. If once this is absent, you may need to make that initial opening with a needle and then make a vertical slit for about 2 millimeters. If that allows you to have the patent passage, that is okay, but if not, then you make another horizontal passage, horizontal cut in line with the horizontal part of the lower canaliculus. And then you have to try and see, you can remove that triangular piece in between, and you often find that by this maneuver you now have a patent passage, and you can go ahead and intubate it, and this will work to give you a good relief in almost 70 to 80% cases. You remove the tube in about, mini Monaca tube in about 6 weeks time, and this would be a good method for many of these cases. So you can see that the probe can now be passed and syringing is now patent. So canalicular blockages, although there are a number of approaches including the transcanalicular endoscopic approach, but the most practical one is Sisler's trephine, where we have a trephine available to us, where we find out the area of the obstruction. Now this is the Sisler trephine. Once you place it in with the tube, with the outer core, outer part covering the sharp part, and when you remove that outer covering, you can go through and carry out an good trephination, and the passage can become patent. You can then carry out an intubation and retain the tube for 6 weeks, and that works well. The last part is about the conjunctival dacrocystorhinostomy, or a bypass surgery for these cases with upper and lower canalicular obstruction. Now the conventional method is Pyrex glass tubes. Various other approaches have been tried, Medpor coated tubes, mucous membrane grafts, but they don't work as well as the Pyrex glass tubes. we created our own tubes with a chudi manufacturer in Firozabad, which has worked well for us. But there are newer designs available, such as a stop-loss tube, where the extrusion rates have been reduced by the presence of the sleeves which allow the tube to be retained better. Now this is the indigenous Borosil glass tube that we had got made, and it works well. So this Jones tube is placed after the posterior flap is sutured, and the tube has to be taken care of post-operatively. The newer approaches avoid the dacrocystorhinostomy and pass a needle directly from caruncle to nasal cavity under endoscopic nasal control, and these have been shown to give comparable results in some studies, which is a less invasive technique. So let's see how this is done. Once you have confirmed your obstruction with your tubes, you then carry out the procedure of excising the caruncle in that area, so that you can then pass your trocar into the nose. Now once that is passed, you have to examine endoscopically to see that you have created an opening which is in the right position, which has the right kind of gravitational force. It should be directed downwards and medially, and it is in the middle meatus, and it is not touching the septum. So all those things you can check endonasally. And you, with the probe initially, you can see, pass it up to the septum, take a tube which is 2 millimeters smaller than that, and use a probe to support it and go through the passage that you have created. Now once this is passed, you need to see the tube in the nose, make sure that it is not causing, it's not touching the nasal septum and is positioned rightly. And then you can carry out the suturing which has been passed through the tube with a Prolene suture to retain the tube in position. So endoscopic and transcanalicular surgery that have taken place recently have all made a lot of difference in certain hands, and some people are very fond of those techniques. The transcanalicular laser DCR technique, though, has been short-lived, and the results have not been gratifying and has largely been discarded. Endonasal DCR is certainly a popular technique now, and the endoscopic DCR is often done with or without intubation, with or without mitomycin C. With good surgical techniques, the results are almost the same as external DCR, and it can be a less invasive surgery. Thank you very much. I hope you're given a brief glimpse of some of the newer techniques.
So that is from the congenital, please. So from congenital, as sir in one of his slides mentioned 3 years. So there is a controversy at what age we should go for a DCR. But in external DCR, definitely 3.5. So that nasal bridge generally grows. But with an endoscope at the age of 3 years also, or even in that less than also, we can try. Because that ENT colleague says that in endoscope there is a destruction from the above. There is a control is little difficult. From the nose, they can control the nasal contour in very nice way. That's why. But biggest advantage is that a small probe is required. There is a probe size is very, very small, which is not easily available with the hand of the ENT surgeon also. The probing, timing of probing, and as I already mentioned, that's a massage Kriegler. So I generally express in ways of pressure. So there's a hydrostatic pressure which can close it. That's all. So that is our time is over. If no more questions, with the thanks to all my faculties, and especially Dr. Sir with the lots of presentation, but still he just allow me to include. And if no more questions, then I can hand over our dais to the next.
Let's take a good photograph.
Good photograph.
After a good photograph. Rituja, please come.
You will be missing.
Abhijit,
आगे आ जा